Today we are discussing a factorial randomized trial regrading parenteral lipid dose and bilirubin neurotoxicity in extremely preterm infants. The main question is simple but clinically very important. In extremely preterm infants, can the usual parenteral lipid dose increase the risk of bilirubin-related brain injury? Extremely preterm infants often need parenteral nutrition soon after birth. Lipid emulsions such as soybean oil-based intralipid provide essential calories and fatty acids. Many centers increase lipid dosing up to 3 grams per kilogram per day. But there is a concern. Lipid infusion can increase free fatty acids. These free fatty acids may compete with bilirubin for albumin binding. When bilirubin is displaced from albumin, the amount of unbound bilirubin can rise. This matters because unbound bilirubin is the form that can cross into the brain and potentially cause neurotoxicity. So the investigators asked, would a lower lipid dose reduce bilirubin neurotoxicity? They enrolled extremely preterm infants born at less than 27 weeks gestation or weighing 750 grams or less. Infants were randomized to either a lower maximum lipid dose of 1.5 grams per kilogram per day or a higher maximum dose of 3 grams per kilogram per day during the first 14 days after birth. The primary outcome was BAER wave 5 latency. BAER stands for Brainstem Auditory Evoked Response. This test measures how the auditory pathway in the brainstem responds to sound. Bilirubin neurotoxicity can delay this response, so increased wave 5 latency can be a warning sign. The study included 134 infants. The actual lipid exposure was lower than the maximum target in both groups, partly because lipid dosing was held or reduced when triglycerides were high. The key result was that the lower lipid dose did not reduce BAER wave 5 latency. In other words, based on this primary outcome, the higher lipid dose did not clearly produce measurable bilirubin neurotoxicity in this single-center trial. But the story does not end there. The investigators also measured unbound bilirubin. Average unbound bilirubin levels were similar between the two groups. However, concerningly high unbound bilirubin values, especially values above 40 nanomolar, occurred more often in the higher dose lipid group. Some of these high unbound bilirubin values occurred even when total serum bilirubin was relatively low, around 3 to 8 milligrams per deciliter. That is an important point. Clinically, we usually monitor total bilirubin, but this study reminds us that total bilirubin may not always reflect the amount of unbound bilirubin, especially in extremely preterm infants receiving lipid emulsions. Clinical outcomes, growth, and hospital outcomes were generally similar between groups, so the study does not prove that the higher lipid dose causes harm, but it does raise a safety signal. Some infants receiving higher lipid doses may develop elevated unbound bilirubin, and this could matter in larger or higher risk populations. The authors conclude that a larger multi-center safety trial is needed. This is especially important because lipid practices vary between neonatal intensive care units, and some centers may use higher average lipid exposure than this study achieved. So the practical takeaway is this: parenteral lipids are essential for extremely preterm infants, but the dose may influence unbound bilirubin biology. A lower maximum lipid dose did not improve BAER results in this trial, but higher lipid dosing was associated with more episodes of elevated unbound bilirubin. Total bilirubin alone may not tell the whole story. This paper is not saying avoid lipids. It is saying in extremely preterm infants, we may need better safety data on lipid dosing, bilirubin binding, and neurodevelopmental outcomes. For neonatology and nutrition researchers, this study highlights a delicate balance, providing enough lipid for growth and energy while protecting the vulnerable preterm brain from bilirubin-related risk.